Okay, good afternoon, everybody. I hope you've been enjoying the symposium so far. My name is Raghu Mirmira. I'm a professor of medicine at the University of Chicago. I'm an endocrinologist, and both my research and clinical interests are in the area of diabetes, particularly type 1 diabetes. So as you can imagine, I'm excited about this particular session. Before beginning, I want to once again thank our sponsors, in particular Brian and Catherine Miller, as well as Nada Milekovic and Michael Gray. As I mentioned, this session is about celiac disease and type 1 diabetes. We've heard a lot about type 1 diabetes so far, but I think we're going to dive a little deeper into that and its relation to celiac disease. And we're going to begin this session with Dr. Ritu Verma. Dr. Verma joined the University of Chicago as section chief of pediatric GI and as medical director of the University of Chicago Celiac Disease Center in 2019. Her vision for the center is to develop a clinical program to promote early diagnosis of celiac disease and to fully support patients and their families through childhood until they're off to college. She envisions a comprehensive program where every new patient will meet with a dietitian and a psychologist at diagnosis and periodically afterwards to discuss dietary and lifestyle changes and their emotional toll. So without further ado, Dr. Verma, thank you very much.
Thank you, Dr. Mirmira. That was heartwarming. Thank you. That was a very nice introduction. And I would like to also thank everyone who's decided to join us for this particular session, and I will share my slides. So for the next 20 minutes, I'm hoping that I will be able to communicate with everyone the differences between celiac disease and type 1 diabetes in the pediatric world in terms of diagnosis, prevalence, and management. My slides are not moving. They were moving when we tried.
You can try the arrows on your screen.
Okay, thank you. So I have no relevant financial relationships. And a lot of us, we've heard this from Dr. Green, and I just wanted to give a very, very superficial sort of look at celiac disease. And we all know that it is an autoimmune condition, and it's a prevalence around 1%, and it's growing. And we also heard that it is in the genetic susceptible individual. And of course, it's very unique, not just because we are all talking about celiac disease, but it's unique because we do know the trigger, that's the gluten. We may not know why we get it, but we do know one of the triggers. And then we do know that if we eliminate this environmental trigger, it may lead to an almost complete resolution of the disease. What we also know so far is that it's a permanent sensitivity to gluten. The prevalence is 1 in 100 to 1 in 80 children. We do also know that the first degree and second degree relatives, there's a higher prevalence there. With celiac disease, females, it's twice as common as males, and it's pretty much seen in any ethnic background. As we heard from Dr. Green earlier, of course, the region of Punjab in India does have the highest prevalence, but it really is seen in any ethnic background. And again, just to briefly go through the manifestations of celiac disease alone. So if a child has celiac disease alone, you could have the classical symptoms as outlined there in terms of vomiting, failure to thrive, diarrhea, weight loss, and abdominal pain. And then there are the non-classical symptoms where children may end up with headaches, dental enamel defects, short stature. And again, this varies based on the age of the child. So why is it important for us to know about celiac disease? We do know that if it's untreated, it poses long-term adverse health consequences in children and adults, but definitely in children, you have a malabsorption and poor growth, anemia just based on multiple reasons, but one of the reasons being the malabsorption, osteopenia, we heard from Dr. Semrad about that as well. But one of the biggest things, and one of the reasons that I do want to look at early diagnosis of celiac disease is because of the increased risk of autoimmune conditions. And this is something that is significant in pediatrics. And the most well, one of the most common autoimmune conditions is type 1 diabetes that's associated with celiac disease. So just to kind of dive in a little bit deeper, with type 1 diabetes, we do know that there's an autoimmune destruction of the pancreatic islet cells, and that's the pathogenesis, while in celiac disease, there is the inflammation and destruction of the gut mucosa. When you have a combination of celiac and type 1 diabetes, there are thoughts that it could be possible TTG deposits in the pancreatic islets. We do know in celiac disease about gluten being one of the causative agents. In diabetes, the viruses, environmental factors have really been thought about. And in celiac and type 1 diabetes together, there's no particularly shared antigen that we know of currently. The presentation is different. In type 1 diabetes, the symptoms occur a little bit later in the disease course, while in celiac disease, as we saw earlier, the symptoms can really appear at any time, different symptoms, and they do occur before you actually may even get some overt damage. The combination of celiac and type 1 diabetes, interestingly and frustratingly, often those children do not have many major symptoms from a celiac standpoint, but they do have their symptoms from type 1 diabetes. I will not be touching on the HLA genotype. I know that Dr. Liu will be spending more time there. From a sex distribution, we do know that type 1 diabetes seems to be predominant in males, where celiac happens to be more predominant in females, and that is not the case in children who have both celiac and type 1 diabetes. Celiac disease can occur anywhere at any age, depending on how you actually do the diagnosis, whether it's because of symptoms or because of high-risk family members. With type 1 diabetes, there's a peak incidence at early adolescence. And with celiac and type 1 diabetes, we usually end up with a diagnosis of celiac disease after the diagnosis of type 1 diabetes. And I just wanted to highlight a few other differences between type 1 diabetes and celiac. So the mean prevalence of celiac disease in patients with type 1 is about 8%. It's been described and studied in Caucasians. There's little known about type 1 diabetes and celiac disease in the African American population. And as we heard earlier during the previous two sessions, that is something that is being looked at. And in fact, our own center here, we have a special interest in following some of the patients who are African American and see if there is actually something that's more protective. And that's why the African American may not be getting both type 1 diabetes and celiac disease. And usually the celiac disease diagnosis in type 1 is based on just screening, but not symptoms. Unlike in celiac disease, the diagnosis is made based usually on symptoms. We also know that about 75 to 90% of children, the type 1 diagnosis precedes celiac disease. However, interestingly, there are some cases of celiac disease that may develop as primary and then type 1 develops later, and we'll spend a little time on that later on during this talk. So how do we diagnose celiac disease? The diagnosis, and again, Dr. Green mentioned it very nicely, is based on these antibodies, and I am not going to spend more time there, but usually we do know that the screen that's done for celiac disease is tissue transglutaminase. However, in children, we tend to look a little bit more at the deamidated gliadin IgG as well. So we know that children who have celiac disease, their serology usually comes back abnormal. And we have an abnormal serology, we proceed with a biopsy and hopefully make a diagnosis. And the guidelines for screening for celiac disease alone are pretty clear if you have those symptoms, high-risk families, and so on. Unfortunately, the guidelines for screening for celiac disease in type 1 diabetes, they're extremely inconsistent guidelines. In fact, if you look at these guidelines that were generated by the International Society for Pediatric and Adolescent Diabetes, the guidelines in between 2006 and 2007 were that you screen at the time of type 1 diabetes onset, and then you do annually for the first 4 years, and then every 2 years for the following 6 years. And this seems to have changed in the 2018 guidelines, where it is said that the screening should happen at type 1 diabetes onset and then every 1 to 2 years. And I'm sure we'll be debating that later on in our session. We also know that children who have both celiac and type 1 diabetes, the markers are not that easy to interpret. They may fluctuate, they may normalize spontaneously, even if the child is eating a gluten-containing diet, and they're not really as reliable. So it is really important to understand the markers that one is actually looking at and analyzing it. There was a study, and I'll just mention a couple. There were many studies done, a couple of studies. So one was from Israel. Children with type 1 diabetes between 2007 and 2015, their medical records were reviewed. 425 of the new onset type 1 diabetes patients were evaluated. 34 of them had increased TTG IgA. Out of these 34, 14 had a diagnosis of celiac disease, which was biopsy proven. The rest that were followed over time, after 1 year, 7 of those 34 still had elevated TTG. They underwent the biopsy, which was normal. So very frustrating, right? And then after 1 year, 13 of those original had normal TTG on a regular diet. So it goes back to being very careful as we analyze the results as we are seeing patients. Another study, this was more, well, a review. This was from the Finnish Pediatric Diabetes Registry. 36% of the TTG positive index children developed celiac disease, but the rest did not. So there was a transient TTG positivity at the time of diagnosis of type 1 diabetes. So, you know, we know these things. So I'm going to try and present a couple cases to kind of highlight what we need to do as clinicians. And I am, of course, bottom of my heart, I'm a clinician. So first case is a 10-year-old male who had type 1 diabetes diagnosed in 2017. Since then, having some intermittent random abdominal pain, there was some weight loss around the time of type 1 diabetes diagnosis. No family history of celiac disease, but a family history of inflammatory bowel disease. And this is the celiac serology. The total IgA was normal. The TTG was 39.3, where the norm is less than 20. The deamidated IgA is normal, IgG 21.6, and again, normal less than 20. Endomysial was negative. At that time, an endoscopy was done and the biopsies were normal on a gluten-containing diet. And he went on his own merry way. He really did not have any symptoms, but then recently started having more abdominal pain, came for a visit, more epigastric, maybe dyspepsia, had a repeat serology done. And again, the TTG is about 27, DGP is 31, endomysial is negative. So what does the audience think? We should do an endoscopy? How about you give your answers in the chat? Yes or no, endoscopy for case 1. And while you're giving those answers, I'm moving on to the second case. So second case, similar, 10-year-old, family history of celiac disease, maternal grandfather had type 1. There was screening serology done at 3 years of age. According to mom, the child is HLA positive, not sure which DQ2 or DQ8. And according to mom, the child was having follow-up serology every 2 to 3 years, which was negative. And he was going along on his merry way. Few months, started having some abdominal pain, non-specific. And the last 2 months, he started having some weight loss, fatigue, polydipsia, diagnosed with type 1 diabetes. And at that time, he had celiac serology done again. And as you can see with the results, the TTG greater than 129, deamidated IgG 71.4, endomysial positive. All right, audience, would you do an endoscopy here? Case 2. Case 3, 10-year-old with these symptoms, diagnosed with type 1, no other symptoms, growth is great, celiac serology, TTG IgA was 120 units, a norm with less than 20. Again, audience, would you do an endoscopy on this child? This is at time of diagnosis. 3 months later, so of course you got the answer, the parent did not want an endoscopy. 3 months later, there were no symptoms, type 1 diabetes under control, celiac serology done, TTG 125, EMA 1 to 80. Audience, Endoscopy, yes. Endoscopy, no. This is case 3. So what's the answer? Again, I'm going to just summarize some of the studies that have been done. And this is a sort of a summary of many studies. And bottom line, what came up is that if your TTG IgA is less than 10 times the upper limit of normal, and there are no symptoms, you just do a repeat serology in 3 to 6 months later and make sure that the child is not changing their gluten intake. This is not one where you really want to do a biopsy, but of course you have a discussion with the family. If the TTG is greater than 10 of the upper limit of normal at the time of diagnosis and no symptoms, this is a tough one. You can perform an endomysial antibody. If the endomysial is elevated, you have a discussion with the family and you may do an upper endoscopy. However, if you just want to monitor and wait and repeat the TTG a few months later, that is totally fine as well. If the endomysial is elevated, the chance that this will be celiac disease is definitely higher. If the child is symptomatic and the TTG is greater than 10, most likely the child will end up with celiac disease. And of course, you have a discussion with the family and proceed with an endoscopy and a duodenal biopsy. It has been found that there is a lower risk for subsequent celiac disease diagnosis in people with type 1 diabetes if it is at an older age at time of diagnosis. The serology is less, TTG is less than 3 times the upper limit of normal. And if the first TTG was high, but the second TTG within 6 months of diagnosis is low, the chance that you will develop celiac disease is much lower. If your titers are still high, the chances of celiac disease are much higher. We do know that there are many children who have positive celiac antibodies at type 1 diabetes, and a little more than half of them will have persistent antibodies. And this is, again, a combination of many different studies that we've looked at. So if you have positive celiac antibodies, you'll probably end up with persistent antibodies, at least half of them. And approximately a third of these patients who had positive antibodies will actually become negative even on a gluten-containing diet. So it goes back to the point of really being very careful calling someone celiac disease in the setting of type 1 diabetes. The risk of celiac disease reduces 3 to 5 years after type 1 diabetes diagnosis. I am not going to be talking about the treatment because I don't have time. And also we have a wonderful dietitian coming on board. The only thing I would say is it's extremely important to follow up with a knowledgeable dietitian. So why screen for celiac disease? So what are the complications? So one of them is the microvascular complications. So we know that type 1 diabetes with celiac disease, in this combination, they're most likely, they're 1.263 times as likely to develop retinopathy. And nephropathy is another one that is very highly likely when you have both type 1 diabetes and celiac disease. It has also been looked at, these studies done in 2013 and 2011, that the retinopathy was dependent on time since diagnosis of celiac disease. The longer the duration of celiac disease, the stronger predictor of future development of retinopathy. Neuropathy is something that was not seen in this cohort from the Swedish National Patient Registry between 1969 and 2008, though I think that that might be disputed now. But there really was no difference in later neuropathy for those with both type 1 and celiac disease. Glycemic control, and I know I don't have much time, so I'm going to go through rapidly. It really is very confusing. When you look at this table, you find on the left that these are studies, these 3 studies showed that if they're looking at those studies, they were worse with undiagnosed celiac disease and definitely most likely better with gluten-free diet, while the studies on the right side did not have any difference. So a lot of confusion in terms of what happens to A1C and hypoglycemia. I'll go through this most recent study that I saw. From August 2019, there were 608 pediatric type 1 diabetics with biopsy-proven celiac disease. When they were followed 3 years later, those who were celiac negative, TTG negative, you found that the outcomes in these groups, the hemoglobin A1C was the lowest, even lower than children who had just type 1 diabetes by themselves. There was a more favorable lipid profile and improved growth. Cardiovascular disease has been sort of gone back and forth. And again, I don't have time to discuss, but there are some points that there might be an association with cardiovascular disease and celiac disease and type 1 diabetes. Bone health, I will not spend time because Dr. Semrad did an excellent job earlier. But looking at these studies, we do know that there is, in children, there is altered bone health, and it's unclear whether the gluten-free diet by itself will be helpful. But we do know that looking at vitamin D supplementation and encouraging weight-bearing exercises is really important. Growth, again, studies done to show that there is benefits of screening for celiac disease on growth and thyroid disease as well. Does the gluten-free diet help? Yes, it helps by increasing hemoglobin, MCV, ferritin, and then I'm sure Lori will spend more time there. And I just wanted to do one last thing here, and this is where people talk about, can you get type 1 diabetes once you've had celiac disease? So looking at this famous study by Dr. Ludvigsson, there was a Swedish National Inpatient Registry between 1964 and 2003. And when you look at these studies, you do find that there is a risk increase of children who have had celiac disease diagnosed first, that they can actually end up with type 1 diabetes. The highest risk is within 5 years after the celiac diagnosis. So where do we go from here? I'm sorry it took too much time, but lots of questions, maybe some answers, but we do need multi-center collaborations. I do want to thank all my colleagues here at the University of Chicago in the GI section, the Celiac Center, and I don't want to forget my friends in Philadelphia at my previous Celiac Center there, my patients who are here, and those that are left behind in Philadelphia and New Jersey. I do want to have a special thanks to Dr. Liu and Dr. Stahl, who helped me with some of these slides and discussions about diabetes. So thank you, and I'm sorry it went ahead up too much time.
Thank you so much, Dr. Verma. That was a great talk, and I'm sure we'll have plenty more questions during our discussion section. So, and actually speaking now of Dr. Liu, he's actually our next speaker. He is a professor of pediatric gastroenterology and director of the Colorado Center for Celiac Disease at the Children's Hospital of Colorado. And he's going to be talking to us about TEDDY, the Environmental Determinants of Diabetes in the Young, which was is actually an ongoing study. It's a birth cohort, which really provides us a unique opportunity to look at the determinants that might give rise to type 1 diabetes, and in this case as well, celiac disease. Dr. Liu.
Okay, there we go. All right, thank you so much. Here are my disclosures. And so the overarching goal for TEDDY is really to elucidate the etiology and pathogenesis of type 1 diabetes and celiac disease, and really to inform new strategies that could prevent or delay disease. And so this is like the TEDDY study group, and it really does take a village, and this is not everyone in the study group. In particular, we have to acknowledge Dr. Jeff Krischer, who's the PI of TEDDY, from University of South Florida in Tampa. And so the environmental determinants of diabetes in the young. So it's an observational study with a 15-year follow-up at 6 clinical centers in Finland, Germany, Sweden, Colorado, Georgia, and Washington State. And so it's following 8,667 kids at this point who have HLA-DQ2 or DQ8, who have been selected mostly from the general population, but also some who are first-degree relatives of individuals with type 1 diabetes, and they're followed from birth up to 15 years of age. And screening for celiac disease starts at 2 years of age by analyzing the serum samples that are collected for TTG antibodies. And so the outcome definitions for celiac disease in TEDDY are either having celiac disease autoimmunity, or which is basically TTG positivity in 2 consecutive samples, which would be at least 3 to 6 months apart, and then having celiac disease, which is having a biopsy or a mean antibody level, like a very, very high TTG level. So again, TEDDY is an observational multi-center 15-year follow-up study. And we start off with newborn screening for HLA from the general population, right? And so this took place between 2004 and 2010 where over 400,000 kids were initially HLA typed. And from this population, most of these kids came from the general population, and then some with, again, with a relative with type 1 diabetes. And then we found who was HLA eligible, and then they were invited for follow-up. And so this is the breakdown, 7,000, from the general population and almost 1,000 with the first degree relative. And the HLA risk genotypes that we're interested in TEDdy, at least for celiac disease, are those who have 2 copies of DR3DQ2, DR3DQ2, DR4DQ8, 2 copies of DR4, or 1 copy of DR4DQ8. And then there's 5 other genotypes that are really relevant for diabetes only and not for celiac disease that we don't follow. So this is sort of like the TEDdy protocol in one slide. Basically, from birth, these kids come in for a clinic visit every 3 months. And when they become 48 months old, then we follow them every 6 months, unless you're antibody positive. Then they continue going every 3 months. And a lot of stool samples are collected and blood's drawn with every visit. And for the diabetes antibodies, the GAD, IAA, IA2, and the zinc transporter antibodies are measured in these individuals. And then again, for celiac disease, we measure the TTG. In addition to this, we're collecting DNA, RNA, checking the blood, we're checking urine, nasal swabs, doing toenail clippings, collecting tap water. They're getting regular interviews with a lot of questionnaires about infections and antibiotic use. The children do 3-day diet recalls. And then the screening for celiac disease, again, starts at 24 months of age and is checked annually. Now, if someone becomes antibody positive, then all the blood samples that were collected but not tested previous to that one is also tested so that we can actually determine the earliest time point at which autoimmunity developed. So these are like the numbers of questionnaires and samples and TEDdy visits, just to give you an idea for how large this is. So for example, 8,000 visits, 8,000 stool samples here. We have the diet records and 24-hour recall. And at this point, the median age for a TEDdy child is 12 and a half years. And so we do have some kids who are already 15 years old and they've actually aged out of TEDdy. So we're certainly not enrolling any more subjects. So out of those that were eligible, we had 6,916 that were screened. And of course, the majority of these individuals were TTG antibody negative. And of course, we had 22% that were positive on initial testing, okay? And out of those, the majority of them actually were confirmed, okay? They continue to be positive. So we had 1,325 that have been persistently TTG antibody positive, and that reaches our primary outcome for TEDdy. And out of those, we have 540 that have been biopsy proven to have celiac disease. So there's certainly a big gap between those who have persistent antibodies and those who've been diagnosed with celiac disease. And we do have criteria for this. Basically, if you have high levels that are persistent, we can also make that diagnosis. But it's true that there's a lot of individuals still that remain undiagnosed. Okay, we know that some of these antibodies may be transient, and there's been a couple discussions about that earlier. And the reality is that some of these kids actually went self-treated. So they had antibodies that were positive and they started to treat themselves with a gluten-free diet. And this was especially more common in the United States than in Europe. So for celiac disease and diabetes, we see that autoimmunity begins in early childhood for both, okay? The TTG antibodies really, and the diagnosis of celiac disease really peaks, around 2 to 3 years of age. And so when it happens very, very quickly, okay? And then the incidence starts to slow down as you get older. And same for diabetes, these autoantibodies, they rise sharply by 9 months of age. And then the multiple islet autoantibody incidence really starts to decrease afterwards. So I'm not a diabetologist, right? But this is sort of like the way I look at diabetes as a general model that we try to apply for celiac disease. You start with the genetic risk, and then something happens, a trigger, and you activate the immune system. And then you get the immune response. And with the immune response, you start to detect islet autoantibodies, okay? And that's considered stage 1 diabetes, when you actually have detectable antibodies. Stage 2 diabetes is when you actually start having subclinical but abnormal blood sugars. And it's only when you reach stage 3 do you actually get clinically detectable diabetes onset. So the message here is that, like, while this is happening, the beta cells continue to decline. And you have to recognize that disease starts well before you can even detect islet autoantibodies. And so now we're looking at the islet autoantibody risk by HLA genotype, okay, and also by family history. So you can see that, you know, DR4, DQ8 is really the major risk genotype, especially when you have DR3, DR4, or if you have 2 copies of DR4. And then here, looking at family members, if you have 2 affected family members, whether it's both parents or a parent plus a sibling, that risk is higher than having only just one parent with diabetes towards developing multiple islet autoantibodies. So it becomes predictive, but still, it's not that great, right? I mean, it's helpful, but it's even more helpful once you start looking at the number of antibodies that you may have. So once islet autoantibodies develop in an individual, this is when diabetes risk starts to become even more predictive. So here you have individuals with no antibodies versus just one antibody. The risk and the probability of developing diabetes is relatively low compared to having 2 or 3 autoantibodies, right? So it turns out that the lifetime risk of developing diabetes in individuals who have 2 or more islet autoantibodies really starts to approach 100%. And it's even more predictive, for example, if you have like an abnormal glucose tolerance test. So looking at the progression now from antibodies to diabetes, all right? So this is really interesting. Now, looking at the progression from having multiple antibodies, you start to look at this by having, from the general population, if you have 1 antibody compared to having 2 antibodies, compared to having 3 antibodies, okay? So having more antibodies really starts to predict how quickly you're gonna progress to actually getting diabetes. And then you add on having a first-degree relative, and that further defines your risk, okay? So it turns out that the risk is higher to develop diabetes within 5 years in those who have 2 or more antibodies, especially when there's a family history. So kind of the summary for diabetes prediction, you know, based on HLA and antibodies is that, yes, we know that HLA alone is less predictive for the development of islet autoimmunity, but once antibodies develop, then the prediction improves. So there's certainly, having multiple islet autoantibodies contributes to risk. So the more you have, the more predictive of your lifetime risk is. And it can also predict the time to progression from antibodies to actual disease onset. And one thing we didn't mention before is that having a normal but an increasing A1C can also predict progression to over diabetes. And so, you know, you have these metabolic markers that can help you really predict disease. And I wish we had something like that in celiac disease, but we just don't, right? So what have we learned about disease prediction so far in celiac disease? And for Teddy, we're trying to look at the genetic and also the environmental factors. So when we look at the development of antibodies in Teddy children followed from birth, we recognize that, yep, within, you know, the first 5 years, you're already seeing a rapid onset of autoimmunity with antibodies present. And it turns out that, yep, having 2 copies of DQ2 is higher than having just 1 copy compared to DQ8. And also, again, the rapid onset occurs. And so, yes, HLA genotyping can help you stratify the risk of getting autoantibodies or celiac disease, but that alone is also insufficient. Now, we have the cumulative risk data for 5 years, but Teddy also has it for 10 years now, just hasn't been published yet. And so, yes, the risk of celiac disease is very much dependent on the HLA genotype, but it's further influenced by, for example, where you were born. Turns out that kids who are born in Sweden have an even higher risk compared to those in Germany or Finland or the United States. Being female really doubles your risk. I mean, it's a 2-to-1 ratio. And then having a first-degree relative with celiac disease also increases your risk. Now, one of the problems with looking at first-degree relative status is not everyone is tested, right? And celiac disease can be a much more silent disease than type 1 diabetes. So if you have diabetes, you're going to know. Whereas in celiac disease, you know, you're not likely to be tested as an adult unless you've had symptoms. And so we don't truly know what the first-degree relative status is for celiac disease all the time. So let's see if I can explain this graph. So I think this is kind of interesting. And this is looking at the progression of having TTG antibodies to actually getting diagnosed with celiac disease. So Here we're looking at the age in months, okay? And now this is for the 503 kids who've had biopsy-proven celiac disease. And so we're going up here as each row here being a participant, one of the subjects. So you're looking across for one child over time who've had serial TTG antibodies tested. And the blue triangle here represents the first time their TTG antibody became positive, okay? And every green dot afterwards basically represents a positive TTG subsequently, all right? And when you reach the orange dot here, that basically means that's when they were biopsied and proven to have celiac disease. And so the distance between having the blue dot to the orange dot tells you like the time it took for them to actually go from seroconversion to actual diagnosis of celiac disease. And so what we see here is that, especially in the younger kids, you know, like a lot of these kids got the diagnosis of celiac disease soon after the blue triangle, which was soon after seroconversion, okay? Whereas in other kids, we're seeing that the diagnosis could take place years after their initial antibody positivity. So you can start to cluster these kids and start to group them in terms of patterns. But one of the messages here is that serology is certainly going to be more objective than biopsies when it comes to looking at timing, right? I mean, there's a lot of reasons why biopsies may be rushed or may be delayed. And there's a lot of personal preference to this. And the biopsy really is a clinical part of TEDdy. It's not part of the research. So when we predict celiac disease based on antibodies, well, in contrast to diabetes, we only have one useful antibody for disease prediction, right? Now, EMA, it can be helpful, but that's not prediction. That's actually like indicative, right? And so when TTG is positive, that can be either predictive or indicative, meaning it can tell you that celiac disease is developing, or it can tell you that celiac disease is present, or again, it may be transient and not indicative of anything. So therefore, when someone's antibody positive, we have no idea oftentimes at what stage of disease they could be in. We certainly do know that the higher levels of antibodies, the more indicative it is of having villus atrophy. But at this point, we're not able to non-invasively determine progression from having antibodies to actual celiac disease. What about using genetic risk scores? Well, this is not a TEDdy study, but there were some collaborators in this study, but this group with Richard Oram certainly did create a genetic risk score for celiac disease. And so we can start to identify those at high risk, based not only on HLA, but also adding all the other non-HLA SNPs into the formula, right? And there's over 50 at this point that have been identified for celiac disease risk. And so yes, genetic risk scores, such as what Sonia mentioned before, are being developed and looked at. And this was done in TEDdy for diabetes. And so they found that combining genetic information from multiple risk loci can improve the prediction of diseases such as diabetes and celiac disease. And then a genetic risk score model could be used then, for example, to recruit infants into early primary prevention trials. And so this is the kind of stuff where, yeah, it's going to provide a paradigm for genetic screening and selection of at-risk infants using family history and HLA genotyping. And so what they found was in diabetes, they could identify up to 25% of all future childhood cases from less than 1% of newborns who had the really, really high risk. So what about environmental factors then? We've looked at the role of gluten and also the role of infections amongst many other things, but we certainly know that those two major clinical trials looking at the timing of gluten unfortunately didn't influence the development of celiac disease. And TEDdy looked at these factors at the same time and also didn't find an association of the timing of the first introduction of gluten towards the development of celiac disease. But one thing that TEDdy did find is that the higher intake of gluten before 5 years of age does appear to increase the risk of celiac disease. Now, in terms of the role of infections, certainly like early life infections may play a role, especially gastrointestinal infections. And in particular, enterovirus infections seem to be associated with the development of TTG antibodies. And so there's this interaction between enterovirus and the amount of gluten consumed in infancy that certainly needs to be confirmed in larger studies. So as we look at all the factors that have been hypothesized or published to lead towards the development of celiac disease in childhood, you recognize how complicated it is. So far, this is sort of what we've looked at in TEDdy. And at this point, I think we've agreed that we're not looking for any more triggers or any other risk factors unless something new comes up. But in red shows you that there's more of an association towards increased risk for celiac disease for celiac disease or for celiac disease autoimmunity. Okay, and in green, it's been shown to have more of a protective association. And then there's been a number of other risk factors that have been looked at that have just been disproven in TEDdy. So it gets really complicated, and like, how are we going to put this story together, right? I mean, how are we going to fill in the gaps? I think doing some kind of prediction modeling for us is certainly going to involve diet, infection, and genes, right? And that's saying nothing about how complicated and variable the immune system is going to be for these individuals as well. And so this is sort of like, this is the perfect storm that we're trying to identify that Bana mentioned earlier. So that we'd love to be able to say eventually that if you have X genes and you get an infection and you eat gluten, then here's your risk. So understanding the relationship for all risk factors, especially the temporal associations, right? That's going to be very important, the temporal part of this. Hopefully it's going to be followed by prediction modeling. And, like the cluster analysis, sort of like that blue-green, that complicated figure I showed you, this kind of stuff can help you look for patterns where you can start to generate hypotheses. And then talking to the biostatisticians, doing like random forest analysis for survival, it can be unpredictable. Machine learning certainly is going to need to be done, but there's going to be a challenge of dealing with censored data and timed event analysis. And I'm definitely not an expert in any of this stuff. And this is where we need help from the community. And so the next steps for TEDdy, as we dig deeper into this mystery, is that, well, one of the main goals moving forward is the integration of big data generated by our omics laboratories and with analytical help from the broad scientific community. Okay, and there is this large scale meticulous banking of study specimens in the NIDDK repository that's going to facilitate access to the samples by the research community for years to come. So this language that's been used by TEDdy, and I think what this is signaling is that it's going to start to open up to the rest of the community, which I really hope happens. Okay, this is where we really want to involve the rest of the celiac disease community to help us study this. As it stands, our celiac disease committee within TEDdy is very small, and so this is going to be the goal, and so we would love to be able to collaborate, but of course it always takes approval from the steering committee and things. But I think we keep on trying to open this up and get access to samples and access to data, and we can try to work together. We really would need to collaborate, but this is on us, not on you guys. So, it's funded by many, many people. Again, I'm just a very, very tiny part of TEDdy and part of the Celiac Disease Committee. And we really especially want to thank all the junior scientists, and their families, really for their commitment in participating in this long-term study. So I appreciate your attention. Thank you.
Great. Thank you so much, Dr. Liu. That was wonderful, wonderful talk. And we'll obviously get back to it with several questions during our discussion session. Okay, so our next speaker is Dr. Lou Phillipson, who's both a colleague and friend of mine here at the University of Chicago. He's an endocrinologist and leading world authority on diabetes. His clinical interests include type 1 diabetes, type 2, as well as monogenic diabetes, which is what we're going to hear about today. He's a professor of medicine and endocrinology. He's the director of the Kovler Diabetes Center and the James Tyree Professor of Diabetes, and is the President of Science and Medicine in 2019 at the American Diabetes Association. Lou, looking forward to your talk on monogenic diabetes.
Well, excellent. I trust you can hear me. Just you can nod if you can. Awesome. So that's great. I definitely want to thank first the organizers and Dr. Verma and Dr. Jabri, with whom I worked for quite a long time. I think one of the pleasures of being here at the University of Chicago is seeing patients really with children of all ages, is how I say. So I have probably somewhere between 20 and 30 people with type 1 diabetes and celiac in my own clinic. And what we're going to do a little bit is discuss our adventure, really, moving from unusual forms of diabetes and monogenic diabetes in general to specifically types of diabetes that overlap with what you've been hearing today. So we're going to move from talking about thousands of patients in the previous talk to one. And also, I'm interested that so many of the names you keep hearing about will also show up in my talk here. We'll discuss that as we go along. I also want to sort of give a shout out to my friends and colleagues and even patients who are listening to this talk. So thank you very much for joining us. So now if I can sort this out. So the disclosure here is mostly funding sources. I don't have any conflicts of interest for this particular talk. I will, at the end, acknowledge some of these folks, but a lot of what we're talking about is now funded by the NIDDK. We've had funding from the American Diabetes Association, most recently from the Helmsley Foundation that I'll talk about towards the middle or the end of the talk. And of course, the Kovler family has been key to what we do. I also want at the outset to talk about all my many friends who have worked with us over the years. I want to particularly mention a couple of these folks right at the outset. On the top left is Graham Bell, who rarely can be seen with a tie and a jacket, and who probably is having a broad smile in that picture. I also want to mention Dr. Ken Polanski, who is the fourth one next to Dr. Rochelle Naylor, who's also been a close partner. And Ken really got us going with Graham in the 1990s on understanding single gene causes of diabetes that led to the work I'm going to talk about. And as you can see, just from looking at all these wonderful faces, that it's clearly an international effort with lots of diversity. And I always like to point out that immigrants get the job done. One of the things, though, that was interesting is to think about the idea of classification in diabetes. So part of this leads to several general themes in our work over the last few years. One is one of simple classification. Now, it's weird that when I started showing the slide of Linnaeus, I had already been to his home in Uppsala, and I didn't realize sort of the racism that underlied this classification scheme. It turns out that he was really talking about classifying people in ways that are completely outside the pale these days. But if we can give him the benefit of the doubt that this was his time, the importance of classification and distinguishing them still is what's driving a lot of our work today. So it means that when we call something diabetes or an overlap syndrome, what does that actually mean? So in terms of monogenic diabetes, which we'll then get into monogenic autoimmunity, there's a lot of overlap from one disease to the next. So part of the classification schema is to think about the different kinds of diabetes. And most of us have, and if you heard in this talk, we talk a lot about type 1 diabetes. But type 1 and type 2 could also, in some minds, have been thought about as a continuum. And there are clearly some genes that underlie both type 1 and type 2 diabetes that can be shown in this sort of Vennish diagram. And in the middle is various kinds of monogenic diabetes. So these on the left are a lot of genes that underlie type 1 diabetes. So depending on the large population being studied, all of these genes have been implicated as making some contribution to genetic risk for type 1 diabetes. The largest risk for type 1 diabetes, as you've already heard numerous times today, is the HLA system, which dwarfs everything else by many orders of magnitude. The second most important gene relationship in type 1 diabetes is something called the VNTR, so a repeat locus in the insulin gene itself that was discovered by Dr. Bell, who I showed you a minute ago. And there's some very interesting other genes. CTLA4 is an interesting gene that controls the immune system and has been a target. You can see here the interleukin-2 receptor and some other genes that I'll be talking about during the course of the next few minutes. And then these overlap genes where there's both genes that look like type 1 and can cause autoimmunity, and then these genes that have been associated with monogenic causes. And I'm going to be talking about a few of these related to autoimmunity. So this notion of overlap and the genetic risk, which we again heard about from Dr. Liu a minute ago, will be a theme here. So what are the numbers? I mean, this is a little bit harder to grasp, but the numbers are big in terms of total cases, but the numbers of monogenic forms is very, very small. So if you think about the 30 odd million people in the United States who have diabetes, and there's another 60 million-ish who have prediabetes, about somewhere arguably 3 to 5% have autoimmune positive type 1 diabetes. About 85% of those will have the antibodies, some of which you've heard about, that are being studied in TEDdy and elsewhere, and especially in TrialNet. Type 2 diabetes, that is the great majority of things. Together, those things about 95%. What are the other few percent? Well, in younger people, we can see a reasonable amount of monogenic forms, and that's really what we've been studying here on and off for the last over 20 years. So the discovery of some of these genes related to MODY, or monogenic diabetes of youth, in terms of glucokinase, HNF1 alpha and HNF4 alpha in particular, were discovered here at the University of Chicago by Graham Bell and his colleague Steve Fiennes at Michigan, and a host of wonderful collaborators internationally. Neonatal diabetes can be separated from monogenic diabetes with a different but overlapping set of genes, where essentially these children are born with diabetes or have diabetes in the first year of life. So we've been studying these now for more seriously and having a registry for the last 12, 15 years or so. We have about 4,000 people in our registry. But over the years, we've also noticed that there are important monogenic causes of autoimmunity. So people who have clear evidence of the autoimmune kinds of diabetes you've been hearing about, but some specific features that have made us seem like there's more to it than just the HLA linkage and a genetic risk score. So in terms of polygenic type 1 diabetes and other autoimmune conditions, what we think about, as you've heard now several times, is that there's predisposition. So that's sometimes the best we can say. So the so-called typical polygenic type 1 overlaps with celiac and with certain thyroid disorders. And one of the groups that's really studied this the most is, in fact, the group that you just heard about, Richard Oram, a few minutes ago. So together with Andrew Hattersley and a wonderful and even amazing set of colleagues at the Peninsula Hospital and Medical Center at Exeter University in the UK, they published a series of papers showing both lots of evidence about new kinds of monogenic diabetes, and then as well key aspects in really monogenic autoimmunity. So looking at polygenic in this table, so we've seen already about the female preponderance in certain autoimmunities. Certainly thyroid is a great example of that, both hyper and hypo. The mean onsets of autoimmunity, as you can see here, type 1 diabetes, as you heard now several times, age 10, but in fact, it can be any age. So our friend Dr. Hattersley at one point thought that any kind of autoimmune diabetes before the age of 6 months or so clearly had to be a single gene defect. Now he's recently published with his group that in fact that's not completely true, and we can see type 1 diabetes related to HLA even at the very earliest ages, and we'll talk about some examples of that. And you can see that in this case that hyperthyroidism and hypothyroidism develop later on, and that we have various sorts of overlaps. If we look at children, and this again is data from the Barbara Davis Center in Colorado in particular, that about 9 to 10% of people with type 1 will have celiac. Overall, if we take all comers, it's in the 3% range, because as you've heard, as people get older, we don't see the nuance at quite as much, but it can be at any age. So the strong polygenic risk, and again, the Hattersley group makes this point, comes from these shared predisposing genetic loci. The HLA-DR3 haplotype is associated with both type 1 and diabetes through that DQ2, and outside of that region, for example, the IL-2, this is the interleukin-2 receptor, a particular polymorphism. And for those of you unfamiliar with GWAS or genome-wide association studies. These are based on what were called single nucleotide polymorphisms, SNPs, and they have this wonderful nomenclature. So RS706778 is one of those IL-2 receptor polymorphisms that has been associated with increased risk of type 1 diabetes, autoimmune thyroid disease, and celiac disease, as well as other autoimmune disorders. And we'll see in a moment that the earlier onset of multiple diseases suggests that there's something interesting going on. One of the things I've been really delighted to be involved with over the last couple of years is a new effort in precision medicine, which includes understanding diabetes and not only its nomenclature, but also the etiologies. So what you see on the right is a position statement that I was part of, published very recently in both Diabetes Care, the Journal of the American Diabetes Association, and Diabetologia, the Journal of the EASD, the European Association for the Study of Diabetes, where we laid out a sort of a manifesto for what precision medicine and diabetes might be. And it means understanding when people walk into your clinic that there's something particular about both their phenotype, as we heard in the TEDdy study, and the genotype. So partly it's an understanding of that genetic relationship, but there are many other aspects of precision medicine. This is just one of them. And what I've emphasized over and over again in these sorts of talks is to take a careful family history. So if there's one off, which is the case in most kinds of type 1 diabetes, there is no family history, but there may be a family history of other autoimmunity, and that's very, very important to pick up. In some cases, though, there's these other manifestations of either polysystemic disease or other autoimmunities that can be very early onset, and those can tell us that these folks should be identified for genetic testing. Now, in monogenic diabetes that isn't autoimmune, there is insurance coverage, at least for some folks in the United States, to get genetic testing. So the idea of doing this in monogenic autoimmunity hasn't really come to bear yet, but we hope to make that important. And of course, eventually we think therapy will be directed by the specific mutation, but also if there is a specific gene, it may have other implications for other organ manifestations or other autoimmunities, both for that person and for the others. So when I said we were going to talk about one case, just like Dr. Verma has several specific cases, I'm going to talk about a few very specific ones. So in this case, this was a male child who had hyperglycemia in the first day of life. So when I started doing this work about 15 years ago, I didn't think such a thing ever happened, but now we actually have hundreds of such cases in our registry, and they're far less uncommon than we thought. So this child was born small for gestational age at 37 weeks. You see there, less than 2,000 grams with a significant score under the mean. And this child had a genetic risk score for diabetes tested. So this is a GRS, and it's by the same group that you heard about for the celiac score. So Richard Oram and Dr. Hattersley and their group at Exeter were key in developing a genetic risk score for type 1, which includes key single nucleotide polymorphisms that tell us about the HLA region. And in this case, the genetic risk score was low, less than the 5th percentile. So we've categorized them in particular ways, and this particular child also was not positive for the high-risk allele, and that's reflected in the genetic risk score. The child was sick, poor weight gain for several weeks. Eczema is a recurrent theme here in these overlap syndromes, but also liver and kidney blood tests that were abnormal, anemia, low platelet count, and critically for this syndrome, diarrhea. So this syndrome is associated with what's called the IPEX syndrome, with an X-linked immune syndrome that includes type 1 diabetes. And sadly, many of these children die of a variety of things, dehydration, but also even graft versus host disease. So you see in the side box there, the risk score for type 1 diabetes is looking at those top risk alleles, just the same as you heard for celiac, summing their effective weight, and then a numerical score is identified. We're doing this now in all of our patients who are being referred for monogenic diabetes to see if it's possible there's an antibody negative autoimmunity associated with it. And we're also doing it in another study that we're doing also with Dr. Krisher, who, as you heard, is the PI of the TEDdy study. So I'm involved in a study called Radiant, which is looking at atypical diabetes. It looks more like type 2 diabetes, but doing this genetic risk score is helping us to sort out folks who may have an overlap syndrome or occult type 1 diabetes. So it's type 1, but the antibodies may not be there anymore and otherwise can be hard to sort out. So this T1 GRS is not available commercially, but it's incredibly inexpensive, only a few dollars per patient, and it's something that may sort of be enough for prime time pretty soon. So this genetic testing revealed the mutation in FOXP3. It's an X-linked condition that typically involves diabetes in the first year of life, although there are exceptions. There are other multiple autoimmune conditions. And it was, the idea is that one has to look at the entire picture to get a sense of whether the condition is involved. And in some cases, bone marrow transplantation is necessary. And already 25% of the cases in our registry are people who've passed away. Now, in this other situation, there are variants. So by doing the registry, we have increased the number of subjects in our population so that we've expanded the number of cases that we've been looking at. So given that, we have a situation like this one where there's still a low T1 DGRS score, but with puberty, short stature, and so on, the entire spectrum of the disease is much increased. So even though this particular person was thought to also have celiac disease, it was probably the gastroenteropathy associated with IPEX. So just to finish in the next few slides, these monogenic autoimmune genes are growing in frequency and recognition. So in addition to FOXP3, there's also several families identified with interleukin-2 receptor mutations, with LRBA, and then the 2 STAT genes, including a paper just this week from Mark Anderson, who's the first speaker today. And Mark, as you saw, was one of the people who really made us more aware of the AIR gene, AIR. So the phenotypes are variable, but it matters quite a lot to understand recognition and possible other aspects. So what we've been doing is doing more research-based genetic testing. We currently follow, as I said, about 20 folks in our study with monogenic autoimmunity. There's another at least 20 in our study who look to have monogenic autoimmunity, but are not yet identified with a gene. And I'll finish with these sorts of ideas. One case that we worked up together with the group at UCSF, Mark Anderson, Mike German, and their colleagues with funding from the Helmsley study, is a young woman now in her 20s who I've been seeing for the last 7 or 8 years. She walked into my clinic with this picture that she was diagnosed with diabetes at age 14. She had positive diabetes antibodies associated with type 1 diabetes. She'd been on insulin throughout her life. Her type 1 diabetes genetic risk score was intermediate, and she had these syndromes all in one person: eczema, hypothyroidism, a mixed connective tissue disorder, gastroparesis, multiple food and seasonal allergies, fatigue, headaches, elevated liver function tests, and Raynaud. She's also been worked up for celiac a couple of times, but we were not able to make that for sure. And we have now done genetic sequencing on her and her family. And we think we may have an answer to that situation, which is currently being evaluated, a single gene not currently known to be involved in these sorts of overlap syndromes. So thanks to the Helmsley Trust and our collaboration with UCSF, we're doing quite a few other families, finding genes that had not been associated before, because looking at one family gives you a very different flavor than looking at multiple, looking at sort of thousands of people where genes may not be seen. So again, what we're looking at is understanding these connections between genes and phenotype. We're trying to make sure people take a family history and look to see when these various elements like eczema or gastrointestinal issues, when they come up, the earlier they come up, the more likely it's related to a gene. I wanted to thank some of my colleagues who passed away. So especially in this case, Steve Fiennes, who really launched us with with our studies in monogenic diabetes at the University of Chicago, some of our team members in the Kovler Diabetes Center, the families that participate in so much of our research and our family studies for monogenic diabetes, and our website is there. And to thank then our collaborators and funders, and in this particular case, not only the group at Exeter and Peninsula Medical School, but Mark Anderson and his colleagues. So thank you very much, and I look forward to your questions.
Great. Thank you so much, Lou. And we'll definitely have several questions. I've already seen a couple in the chat. Okay, we'll move on to our last presentation in this session by Lori Wellstead. She's a registered dietitian in the section of gastroenterology at the University of Chicago. She sees a variety of adult patients who have GI conditions ranging from celiac disease, Crohn's, and ulcerative colitis to irritable bowel, fatty liver, and obesity. She has a passion for promoting health and wellness through nutrition education and helps individuals develop realistic, gradual changes that are tailored to personal preferences and lifestyle. So, Lori, we will look forward to your talk. Thank you.
Thank you very much. Okay, so I'm excited to be here today talking about the gluten-free diet in both celiac disease and type 1 diabetes. I have no disclosures to make today. I did want to note that I am a registered dietitian that's trained in GI, and so I do see a lot of these overlap patients, but we do work closely and try to collaborate with the endocrinology team, as most of these patients are already seen by an endocrinologist. So today we'll be reviewing the gluten-free diet guidelines for both celiac disease, as well as that overlap in those patients with both type 1 diabetes and celiac disease. Some of the challenges we will discuss with regard to adherence of the diet, as well as optimizing the diet for blood sugars and overall nutrition. So as I was researching this, I wanted to try to get a handle, and we've talked a lot about this today already. And as we know, 1% of the individuals have celiac disease in the population. And in the US, approximately what I found in my research, about 1.3 million have type 1 diabetes. And as we've discussed today, it's up to even 8% of those individuals with type 1 diabetes also have celiac disease. As we've discussed repeatedly today, type 1 diabetes typically precedes celiac disease. So again, in 75–90% of those individuals that have been studied, they have type 1 diabetes first. As we know, it's usually higher to have the overlap when they are diagnosed under 4 years of age. They may present with the growth failure and delayed puberty. And then I wanted to touch on the fact that this small study here, this was looking at patients with both type 1 diabetes and celiac disease, and 13 out of the 17 biopsy-proven celiac patients with type 1 had greater or more than one GI symptom. And although some of these were more mild symptoms, fortunately, they all resolved in the children on the gluten-free diet after 1 year, as well as their BMI and their weight. So just to kind of give a scenario of when a patient comes in to see me on a first visit. So I like to, again, I know they're already typically established with endocrinology. So I like to kind of go over what their current intake is, as well as kind of seeing, what their current intake, what I mean by that is on a gluten-containing diet, to see if we can find some good swap outs that are going to be more realistic for their lifestyle and more for sustainability. I do like to touch on the fact if they do have GI symptoms. So is this patient experiencing constipation, diarrhea? Do they have horrible gas and bloating? Nausea is another very common symptom we see in our patients. And then also just kind of looking at some of those studies to know, does the patient have any kind of rapid motility? Or again, if they have long-standing diabetes, do they have delayed gastric emptying? So these are just some things that I like to kind of get that whole picture. And also we do want to ensure that these patients are securely diagnosed with celiac disease. So typically in my initial note, I like to obtain those celiac serologies from diagnosis, the biopsy, and if as needed, the HLA-DQ 2 or 8. Also, just kind of baseline knowledge. Does a patient have a history of anemia? Do they have any other vitamin mineral deficiencies? And again, as we've discussed today, typically within that first year after being on the gluten-free diet, a bone mineral density may be drawn, may be done. And then lipid panel. So we know patients may have elevations in their cholesterol on the gluten-free diet due to proper absorption. So again, just kind of touching on some of these so that I have these as a baseline for moving forward. And then lastly, really knowing, are they taking a boatload of supplements and medications? And again, what are their knowledges, beliefs on the gluten-free diet? Some patients might come in and they're ready to go. Other patients are really not ready. So it's kind of accessing, figuring out, what is their access to food? Do they like to eat out? Are they mostly eating at home, to try to kind of get that basis for that patient? So as we've discussed today, there are a variety of different ways that patients may present. So patients may just have osteopenia or osteoporosis and have no GI symptoms. So again, knowing what their vitamin D levels are to make sure that we can optimize that. And again, supplementing as needed. This just basically shows some of these common presentations that we might see with patients. And then also what some of the nutrients dense food sources are. We do recommend that our patients take a gluten-free multivitamin with minerals. I always say it's kind of like a backup insurance, because oftentimes they may not be consuming an adequate diet. And also, lastly, these gluten-free processed foods are not going to be fortified like their counterparts are. And so again, some of the challenges when these patients are embarking on the gluten-free diet. So again, this individual who already has type 1 diabetes might be coming in and have this really big shock from the diagnosis. And they really do need to have that space to mourn the loss of gluten in their life, right? So this is all encompassing. It affects many different parts of their life. So whether it, we discussed some of the things with eating out, going to parties, traveling, some of those different things to touch on at that visit to see where they are. And then lastly, as we know, there's been multiple studies now looking at the quality of life in individuals with celiac disease. And we'll talk a little bit more about type 1 and celiac and the quality of life. But we do know this extreme vigilance really can negatively affect individuals socially and emotionally regarding their wellness, and exacerbate that anxiety and fatigue. So gluten. So gluten in Latin is for glue. So gluten, again, provides that structure, that texture. I like to say that a croissant is like the perfect example. So again, a croissant is going to be flaky, fluffy, crunchy, crispy, all of those amazing qualities of the protein gluten. And as we know, gluten is that protein, it's a storage form of protein in wheat, rye, and barley. And it retains moisture in products. It also helps extend fat and protein. So again, when I started out as a dietitian, approximately 20 years ago now, it was in a lot of fast food meats. And clearly nowadays that's not the case. But when I first started out, that was quite common. So some of the gluten-free diet basics. So as we know, as it's been hammered in our heads today, celiac disease is triggered by the ingestion of gluten. We recommend avoiding wheat, rye, and barley and any derivatives of those grains. I don't have enough time to talk specifically extensively on oats, but oat and oat products that are certified gluten-free, I really actually promote even purity protocol for most of my patients. And we do know there is a subset of individuals that cannot tolerate the avenin, the protein in the oats. So again, when in doubt, leave it out when it comes to other processed foods. So I just wanted to touch on the fact that a lot of patients come in and they're extremely overwhelmed because they have a whole new set of things to consider when it comes to their diet. So what I wanted to reiterate is that, again, when you look at a regular plate, is that these patients can consume their fruits and their vegetables and protein-rich foods, dairy is tolerated, and then just trying to find those swap outs when it comes to the grains. We'll discuss a little bit more here soon about these processed grains. So again, certainly these individuals can consume, tapioca flour and potato flour and rice flour and all these old conventional gluten-free processed foods, but they can definitely add up and not only affect blood sugars, but also affect weight gain. So how much gluten can be tolerated? So a big buzzword in the celiac or the gluten-free community is 20 parts per million. So 20 parts per million is 20 milligrams of gluten per kilogram, or 2.2 pounds of food. So it's a very small amount of gluten that's allowed in something that's stated as gluten-free in the US. As we know, if something is certified gluten-free, there's a variety of certifications, but it might be down to 10 parts per million or even less. There was the Hallmark study in Italy done on how much gluten can be tolerated in individuals with celiac disease. So as you see here, this quarter on the right side, that is comparing that little piece of bread is 50 milligrams of gluten. And in these individuals for this study, they either took 0, 10, or 50 milligrams of gluten over 90 days. And that 50 milligrams of gluten did induce villus damage. So a lot of these processed gluten-free foods, as I've been mentioning already here, is that they do have a lot more carbohydrates. Again, the conventional original ones that are out there. So as you can see here, a regular English muffin, gluten containing, will have 120 calories. Well, a gluten-free English muffin will be nearly double the calories, almost double the carbohydrates, and triple the fat. So these are some different foods that if a individual is just grabbing something to swap out, they may not be aware that this would be something that may impact their blood sugars a little bit more severely than something that they might be used to consuming on a daily basis. So as I was doing my research, I wanted to touch a little bit on the whole glycemic index. We talk about portions of foods and whatnot, but I think this is important when you think about some of these specific foods, how they may think of it as being not something nutrient dense, but very dense with regard to sugar. So this all started down at the University of Sydney, and they maintain a database. They rate foods from 0 to 100, and they basically test individuals over a 2-hour period after consuming 50 grams of whatever the food is. And what's deemed high GI or glycemic index is something that's above 55. These foods are rapidly digested, absorbed, and metabolized. And those that are low GI are something that will cause less fluctuation in blood sugars and requirement of insulin. So as you can see here, if someone is consuming barley prior to the diagnosis of celiac disease, the glycemic index is extremely low. It's 22. So this might be something that's an excellent option for this individual for their blood sugars and for getting a really good source of grain and has some protein. On the flip side, if they're now swapping that out for some sort of a gluten-free pasta, you can see here some of the different corn or rice pastas, they can be sometimes more than triple the glycemic index of something that they may have consumed previously. And just for reference, they do compare this to glucose, which is rated as 100, and then sucrose is table sugar, and that's rated as a 60. So just some food for thought. As many individuals with celiac disease and type 1 diabetes may know, there are loads of low carbohydrate swap outs these days. So there's a lot of nut flour type of products, as well as predominantly those almond flour products, bean, predominantly those garbanzo bean products. So there's everything from garbanzo bean pizza flour to pasta, you name it. It's really very popular these days. And what's great is for both these products, they're going to be less carbs, but they also have a good amount of protein and fiber. And then again, some of these Norwegian crisp breads, everything from cauliflower crust to wraps, you name it. Again, a lot of restaurants are also providing some cauliflower options when it comes to being gluten-free. Again, I recommend just checking to make sure it is celiac safe. And then lastly, the common spaghetti squash, which is a great side that's just naturally gluten-free and very low in carbohydrates and quite high in fiber. And then there's all these new cheese wraps and egg wraps and things that many patients are coming to clinic and telling me all about. I just wanted to quickly touch on the fact of lactose intolerance. So sometimes patients are coming in, they're feeling so restricted and they may not have the best symptoms. So I wanted to touch on the fact that you may not need to be necessarily dairy-free. You may have a little bit of sensitivity to lactose because of the initial diagnosis. So when you do have your scope and they go down to the duodenum, they take a biopsy of your villi in that area. And on the tips of those little villi are where the lactase enzymes are. So if in fact your villi are smushed down to the line of the intestine or diminished in some sort of way, your enzymes are basically asleep. And so once you do go on the gluten-free diet, you can typically involve lactose back into the diet. And if that's not the case, just remembering things like hard cheeses and butter are lactose free, and then making sure, you can also find like lactose free dairy products or take an enzyme prior to consumption. And again, just wanted to touch on this because I think a lot of people are over restricting and think that they have to be dairy free, gluten free, soy free, and a million other things sometimes. We do know type 1 and celiac disease are primarily managed by the diet. Now, we know type 1 is also obviously managed with their insulin, but these individuals may omit or binge on their insulin or develop a restrictive diet because all of this is related to this impacts their weight, this is impacting their body shape. And we do know that type 1 diabetic females are more than about 2.4 times more likely to be diagnosed with an eating disorder. I wanted to touch a little about this really interesting study looking at adaptive and maladaptive eating. So again, kind of this whole picture of when you're talking to these patients, we don't really realize sometimes what might happen. So again, is the patient, tending more towards flexibility, or are they very rigid? Are they trying to avoid foods and rather than really not trusting? So again, confidence versus control, awareness about the gluten-free diet, or are they obsessively preoccupied? And in this study, about 53% of those individuals with celiac disease reported maladaptive eating behaviors and really diminished quality of life on the gluten-free diet. And their recommendation is to follow up specifically with a GI physician and with a registered dietitian, and then psychosocial support referrals as needed, and not forgetting it's not just a one and done, which can often happen with a diet education. So quality of life, we do know quality of life is often diminished. And so those individuals with both type 1 and celiac disease, their scores were lower than just type 1 alone with regard to social functioning, general health perception, and a higher burden of illness. And as you can see here, the adherence of the type 1 and celiac disease, type 1 adherence to the diet is quite low in both type 1 and celiac and just celiac disease alone. I wanted a quick touch on self-regulation. So again, it's something that can be taught, and it's basically a process that you can self-manage your behavior. So a lot of individuals are coming in and they're trying to figure out, what foods might be causing symptoms. Again, trying to figure out what foods might exacerbate your blood sugars. And so this is something that's very important, but it can also go awry with some individuals. I wanted to touch a bit on self-compassion. So a lot of times patients and individuals are able to be very compassionate towards others, but not towards themselves. And so this is a positive way of relating to yourself and a sense of common humanity. Justine Dowd and I are in this picture below here, and this is in Prague. In 2015, I met her at the International Celiac Disease Conference Symposium, and she taught me all about self-compassion and their studies that they're doing up in Canada. And so this was the first study that related that coping mechanisms with celiac disease and that strict gluten-free diet adherence. And they found that learning those tools of self-compassion really helped to predict their adherence to the diet. I wanted to talk about a couple patient perspectives. So Brianna, first of all, is 25 years old currently, and she was diagnosed with type 1 in 1999 at the age of 4. Approximately a year later, she was diagnosed with celiac disease. She is the second patient of Dr. Guandolini, and so she is a great advocate for celiac disease, and she jokes that celiac and type 1 is a cruel joke, and that almond flour is one of the best things to happen to the gluten-free community. And for her, that since she's had it for so long and had to adapt to it, right now she claims that her blood sugars are more the difficult element than only the gluten-free diet. And so as we were conversing, she did mention that, for her, it's very important that all foods fit, right? So there's this big rise of restrictive eating in our society. And so I think this is something that's very important that dietitians and clinicians need to take note of. And there's her contact information if you want. She has some great restaurant guides in Chicago, local information as well. Another patient perspective is Harper, who is 5 years old. Currently, she was diagnosed with type 1 at 18 months and 7 months later diagnosed with celiac disease. Her mom initially took the celiac harder because it took her so long to really adapt to the diabetes diet. And so she said her biggest takeaway was that the team stressed, eat anything, just take your insulin. And so that she could initially start to enjoy those close substitutes and then kind of find what was worth it to her to that might be a little more dense with carbs. And her mom said, besides keeping her healthy, it's important to make her feel like a normal kid as much as possible. So that really rang true for myself and for a lot of patients. So again, some food for thought: naturally gluten-free, minimally processed foods should primarily be a good chunk of the diet. It's fine to have some processed foods. Processed foods should not be the villain, but I think it's good to be mindful of that. Some of these foods will be a lot more dense with regard to carbohydrates, calories, and we know these patients are going to be absorbing more properly on the gluten-free diet. And I like to, again, in my clinic, like to focus on foods of what to include versus what to exclude. And portion control, as we know, is key. And then I always like to educate patients on making sure that they are moving to help their blood sugars, as well as avoiding weight gain on the gluten-free diet that might be unintended. So in conclusion, a strict gluten-free diet really is the only current treatment for celiac disease, and dietitians play a crucial role in the education and the adherence of the diet. As we've discussed today, a goal is really just a balanced, varied diet. There are some different considerations with regard to type 1 diabetes and the choices when it comes to these processed gluten-free foods. And I hope I brought some awareness surrounding some of these disordered restrictive eating patterns. And lastly, collaboration truly is key with regard to GI, endo, and psychology as needed. Thank you very much.
Thank you very much, Lori, and to all of our speakers. Now, we had only scheduled a little bit of time for discussion. However, what we're going to do is kind of go up until about 2:40. I know we're going right into our break, but for those of you who would like to stay on, please do. And I'd like to get to some of the questions because there were several. And what I'll do is let me start the discussion off with Dr. Verma and Dr. Liu, and then just kind of move down. So, Dr. Verma, one of the questions that was asked by the attendees is regarding adult patients with, we'll kind of broaden it to not just celiac disease, but perhaps with type 1 diabetes. First, how often should adult patients see their gastroenterologist? And also, do you have any recommendations for screening adult patients with type 1 diabetes for celiac disease?
Okay, so first of all, I think that they should, it's a question about seeing a gastroenterologist. In my opinion, I think that if you're diagnosed with a condition that is a GI condition, you should see a gastroenterologist at least once a year. And at the same time, you should be seeing the dietitian as well. I think it's not just a matter of doing a blood test and moving on. So in my opinion, that's what should happen. And I think it's the same for children, even when they are stable. Now, if somebody's, looking at the growth phase, then we see them more often, but at least once a year if everything is going fine. And then the second question was looking at blood work.
Well, no, I was just asking the question, screening adults for celiac who might have type 1 diabetes. Are there any recommendations?
I think I'll ask Dr. Phillipson to help us with that in terms of the adults.
Yeah,
Lou,
so
do you have any suggestions?
I can say, so, I'm an adult endocrinologist, as many of you know, but I do see kids. And so I learned to screen from my pediatric endocrine colleagues. Adult endocrinologists, by and large, never screen for celiac. In fact, other than screening for thyroid disease, I don't think there's really much screening at all for other endocrine immunities. I will, at the drop of a hat, given sort of the number of all the other implications, especially osteoporosis and lymphoma. So I think adult endocrinologists, generally speaking, probably need to be more aware of screening for celiac in those people who have even subtle, it could be a subtle anemia, lots of other issues that otherwise, I think it's not on the top of our tongue.
Thank you very much. And I guess this was directed at both Dr. Verma and Dr. Liu, but maybe I'll ask Dr. Liu to step in. How about when should you consider doing an antibody test for other autoimmune diseases, such as type 1 diabetes in children with celiac disease?
I was actually going to ask Dr. Phillipson what he thought about this too, but in general, from the GI standpoint, there really aren't the recommendations to be screening for diabetes autoantibodies if you have celiac disease. There's not even recommendations at this point to be screening for diabetes, which, I'm not sure I necessarily agree with. At the very least, I think we should be counseling on the risk of diabetes, because I think that, the risk is going to be like, what, maybe 2.4%. Roughly, if you have celiac disease and then diabetes. And so I think that, when the rare occasion when the family with celiac disease develops diabetes and then they find out that there was a risk, why didn't you tell me that? That's not a good thing.
I just jump in. It's actually hard to find data. I've spoken, so Barbara Davis in Colorado has done this amazing study in process on looking at screening for celiac and type 1 diabetes antibodies. And to some extent, it's also happening in TrialNet that you mentioned in your slide, Dr. Liu. So we don't even know the percentage of people with celiac who go on to get type 1. That's not a number that is, I've asked Dr. Rivers, did Barbara Davis. It's small. It's much smaller than the 9% we think about of the other way around. But I think it's just interesting. Just yesterday, I spoke to a gentleman who has a company that wants to market a point of care antibody test for anti-islet antibodies. And I asked him, why would you do that? It's not clear to me that that's like a thing. But eventually, it may be that it will be inexpensive enough to do it. But the research, as you say, isn't there.
Yeah. I'll throw in one more thing though, real quick. Sorry. I did recently talk to Dr. Rivers about this too. And so it may be a little bit more updated when I told him that, hey, I think the risk of diabetes after someone has celiac disease is maybe 2.5-fold. So it might be, say, like 1.5%, 2%, 1.5%, let's say. He thinks that the frequency of islet autoantibodies would be about 3-fold that. So he's guessing maybe 4.5% of all individuals with celiac disease will have diabetes autoantibodies.
Yeah.
So I guess the question comes on, what do you do with that? Sure. And again, Lou, you mentioned that we don't know, but we don't test. So if we don't test, we don't know.
Well, eventually we will. Just this week, a paper that I participated in on an anti-TNF alpha antibody was published in New England Journal, and we were a site for that study. So I think the idea of interventions early on is growing. TrialNet, and again, there's overlap between the TEDdy people and the TrialNet people. The idea that identifying folks with positive antibodies, more than one positive antibody, may put them in a group for intervention early on. So we're getting there. It's not standard of care yet.
So Lou, I guess maybe just to kind of take that one step further, there was a question that was asked about the utility of screening for monogenic mutations. What might you be able to do to intervene in such individuals? Or is it just basically, a sentence for diabetes and there's not much you can do?
Right. Our colleague, Dr. Kupfer, asked that, and I was pleased to see. I refer to her essentially all of my adult patients and Dr. Semrad with celiac and other GI issues. I think right now there is no particular intervention. I think what we're looking at is, first of all, identifying mutations. One of the ones that we're studying right now looks like there may be a pathway. If you have a gain of function mutation and you can inhibit that pathway, then you may have an interesting option. And one of the criticisms in the paper we just submitted was maybe this is irrelevant to type 1 diabetes. If you have a one-off and this is the first example of that particular mutation, what good is it? But I think this profound implication is the pathway. So it may be that finding these rare experiments of nature illuminates a pathway which otherwise we would not have really imagined, because it doesn't come up in large-scale GWAS kinds of experiments. That the advantage of finding these sort of individual cases in that pathway. So in this particular case, there may be a situation of intervention. Now, will it help the particular young lady? Probably not. The horse is out of the barn for a lot of her problems, but it may be that it could be one more kind of intervention in people with other kinds of autoimmunities.
Let me bring in one issue that I think has been kind of bantied about in a few of the questions, and that is Dr. Liu, you spoke about genetic risk scores that Dr. Oram has been developing, particularly with regards to type 1, but also celiac disease. What might be the role of genetic testing and in terms of identifying risk for celiac disease? So if somebody's got type 1 diabetes, would HLA typing be of any value? Is that something that we should be thinking about in practice versus just doing versus research?
I'm not sure. I mean, I think in practice, I mean, it's going to be useful just to exclude. But if someone has type 1 diabetes, I think we're going to assume that they already have the permissive HLAs already for celiac disease. I mean, and the reason why I think that diabetes occurs first typically, and then celiac disease follows, is just because DR3, DR4, is a high risk, for the most part, for the young kids to get early onset diabetes. And it's also very permissive, for celiac disease, So, I mean, HLA on its own wouldn't be enough, but we would need, all the other SNPs involved to really provide a risk score. And I think the utility of this would be for either in the future primary prevention trials or disease interception. Really looking forward to something like that.
Dr. Verma, anything to add?
So I will disagree with Dr. Liu. and we've had these debates in terms of I think celiac comes first, and I wish we would do some of these mass screenings so that we would really know the answer. So in my opinion, and only my opinion, I think, is that if you were diagnosed with celiac disease early, then maybe Dr. Phillipson and Dr. Murmura, you may not have as much of a job. But I just, it's one of those things that it would be great to be able to look at it seriously from a antibody, from a science, from a genetic standpoint, and see what happens first. So, Dr. Liu.
I mean, I could just say one of the interesting points is sort of why. I mean, this is the thing. So we mentioned the HLA, leads to early and high predict, but why does it do that? So I think those are the pathways that are critical. I know there's at least one group that's looking at molecules that bind to proteins that are transcribed from the HLA, from specific HLA loci, and just like we saw in the paper, I don't know if somebody saw it today, a coronavirus inhibitor based on molecular design from scratch. So a completely artificial molecule that binds to the spike of coronavirus could inhibit its penetration or attachment to cells. Similarly, molecules we might design from scratch, or in the case of the one I'm thinking about, by accident, doing large-scale molecular screening, basically in silico, you could figure they have already identified a molecule that can slide into an HLA-related protein and inhibit that interaction. So whether that is another intervention in the future, I mean, and what bad things might that do? I mean, we'll have to see.
Yeah. Well, our time is running short. I do want to get Ms. Walstead into this discussion as well. There have been several questions about diet, type 1, and celiac disease. So we've had some questions on cross-reactivity of non-gluten foods causing symptoms in celiac disease, and what are your thoughts on cross-contamination, for example, cooking in the same toasters, using the same knife, et cetera? Is that a concern?
Okay, so those are some great questions. So first of all, as far as the cross-reactivity of certain foods like coffee and corn, that's really, there's no really true data as far as for that. So I don't tell patients that you have to avoid corn and you have to avoid coffee at this time. They're not necessarily going to have a reaction. Their antibody levels will not increase on coffee or corn, right? So of course there might need to be more studies on that. But at this time, I don't tell patients to avoid those foods. As far as cross-contamination, I think there was some really interesting takeaways from those recent toaster studies and with the strainers. But still in my practice, I tell patients to still kind of err on the side side of caution, to be a little bit more conservative and not just take that one study and say, okay, you could use anyone's toaster at this time. Because again, I'm really trying to get their numbers down. But I think it's a great, it's something that I think a great area of research. And I think that the challenge is being a dietitian in this kind of area is that there's not much research on that cross-contamination at this point. So this is very new research, and I think it's very exciting. And I think, you know, that might change the, you know, kind of how we educate. So I think stay tuned.
Yeah, and it seems, you know, like a real challenge for patients with both celiac and type 1 diabetes. I mean, you were talking about, you know, processed foods and what do you avoid, what do you not avoid? But that's a pretty tough situation, I would imagine, when you have both disorders, to try to balance, worsening celiac versus worsening type 1 diabetes.
Absolutely.
Yeah. Any final comments from anybody?
I think I'll agree that it is tough to have both the conditions. And that's why you really need a team to help in terms of manage. It's not something you can do on your own. And, you know, that toaster study was great. And we do need next steps to that. So it just makes quality of life a little bit better, so long as we can know that it's safe. So we just need next steps to that. But none of this is easy in terms of having celiac. And then if you have both, it's even worse. And so the support mechanisms are really important from your clinical team and from home and school and everything else.
Yeah, I mean, it is interesting to think about. Based on all the advances with corona testing, it's possible one could imagine one day a home TTG test that someone could test their TTG at, you know, some interval that we can't even imagine. I mean, maybe weekly, to have that feedback that right now, you know, a year ago I wouldn't even thought about such a thing, but to get a point of care immunity test, those things are amazing. Just one quick question. Someone asked in the chat, an adult diagnosed with celiac disease, should she be tested for T1D antibodies? No, I mean, I don't see any reason to do that. The incidence of type 1 in an adult is low anyway, and to have a double jeopardy like this, right now it's not a high enough incidence to justify.
Well, I would agree with that, and I want to also thank all of our participants on this panel. Terrific talk, and I think we've just run a little over on our time here, but thank you very much. A lot of things, exciting things going forward here. So, thank you, everyone.
Yeah.
Bye-bye.